Testing, 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 testing. Can you all hear me? All's good? Okay. All right then. Welcome to Prostate Cafe. This is our monthly meeting. Typically, it's sort of the end of the month and always on a Friday. So anyhow, I want to thank a company. It's called Dendrion, which provides your breakfast this morning. They're a really interesting company that we've been working with for a while. They have a great product. Cancer therapy has gone more and more in the direction of immunotherapies. And with Provenge, which is what Dendrion, their product line is it's a way of taking someone's blood. For the first process, and you draw someone's blood. We call it leukapheresis process. And then the blood is spun, and you take certain elements from the blood, such as APCs, and they're sent off to a laboratory, which then takes that blood and then generates additional cells, which are put back into you. So it's basically a personalized type of immunotherapy that's put in you, and then those cells call for your own immune system to be boosted dramatically and attack the cancer. So that's what we've been doing. And as I say, more and more we're going down the lines of immunotherapy. You'll read about other cancers too, where there are very few successes, like lung cancers and even pancreatic cancers now, where they're being treated with immunotherapy with success. It's all about mutations. So that's something that we look for. Is there a mutation? And is that mutation, is it something that we can actually target with a specific molecule? Okay. In the past, you all know of chemotherapy. And chemotherapy is not targeted. Chemotherapy is basically, something that's delivered to your whole body. And what it does do is it kills the cancers better than it kills your normal cells, but all the normal cells are affected. So targeted agents are now becoming more important. And as I say, even with lung cancers now, for example, one of the particular types was a lung cancer that had a median survival of 6 months. And those patients are now living a median of 6 to 7 years. And if a person has a specific actionable mutation for pancreatic cancer, they can live for years in a disease that often, takes its toll in a matter of months. So this is definitely a direction. Now, I'm going to take your questions, any and all, about prostate and prostate cancer. But while I'm on that topic, also many of you probably did get your bloods drawn to look for mutations. So we know that prostate cancer follows a genetic pattern, and certain families have many first-degree relatives who have prostate cancer. And they may also have female relatives, first degree, who also have ovarian cancer, breast cancer, and those are on the same allele as prostate cancer in the prostate DNA. Then there's other tumors associated with prostate cancer, such as pancreatic cancer, colorectal cancer, and melanoma. So more and more we're studying that too, the genetic pathways. But it's interesting because even in a man who doesn't have the DNA abnormalities to suggest that he definitely got his prostate cancer from a genetic abnormality, most men don't have that. And they basically have what we call sporadic mutations. And that's the reason why most men get prostate cancer. Having said that, still, sibling of a man who has prostate cancer by a sporadic way still has a 40 to 50% chance higher than the population at large to get prostate cancer. Now, if the patient having prostate cancer has a certain mutation we call BRCA1, BRCA2, they actually have between 5 to 11 times increased rate for prostate cancer, and those patients have to tell their children of this mutation, because their children will also be at increased risk for prostate cancer, ovarian cancer, breast cancer, and colorectal cancer, pancreatic cancer, and melanoma. So these are important aspects of prostate cancer evaluation now. It's a very often genetic abnormality, so we look for ways to target genetic abnormalities. In that case, we call them actionable mutations, meaning there is something in the patient's DNA that we can target specifically. Anyhow, Prostate Cafe, as I said, I'm willing to take any questions you may have on prostate cancer or prostate. Is there anyone out there? Yes, sir.
Morning, doctor.
Yes.
I'm at the excuse me. I'm at the Y right now, deciding about LDR or HDR
Okay.
treatment. So I've talked to you already on the phone. Thank you for that time. It was very nice. And I've also talked to people over at Sarasota Memorial Cancer Center over there last week. And so making that decision, is it a one-time decision only, obviously, between the HDR and LDR, or is it, and what's the difference of the reaction to our bodies?
Okay, so the gentleman is asking about brachytherapy, and there are different types of brachytherapy. The most common ones that are being used today are permanent seed implants, but there's also something called temporary seed implants. And as it sounds, with permanent implants, you put these tiny little pellets, or like dots, into the prostate in a select way, and over the course of weeks to months, it delivers its dose to the cancers, and that's how it works. It eradicates the cancer. In contrast, as temporary sounds, you put these needles into the prostate, and then there's a machine that threads through that needle a radioisotope, and it leaves it in place for 10-15 minutes, and then retracts it, and then you pull out the needles. So I'll give you a long story that's interesting, because I've done thousands of both, and I had a lot to say with high dose rate a long time ago. It was interesting because a prospective patient of mine had contacted me, and he was from the West Coast. He was living in the Seattle area, and he was the CEO of a very big company. He went public with it. It was called Entel. And he contacted me, and he said, you know, he'd heard about brachytherapy, he'd want to know more. And then he went on to tell me, you know, I work 24/7, I just can't leave, and so on and so forth. He said, is there anyone in this area? So I told him, yeah, actually I have a colleague, I've written books with him, and he is in Seattle. And I said, you should go and see him, and I gave him the relevant contact information. Well, that's as much as I remembered, and, you know, everything was fine. About a year later, it was the cover story on Fortune magazine, and it had him. He was the cover story, and so I was very, you know, interested to see what it said. And when I opened it up, I came to find, oh, he didn't have permanent brachytherapy. He had temporary seeds. And, you know, I at that point I said, well, he walked into the wrong door, because he didn't see my friend colleague. He must have seen someone else in the practice. But because of that information, that lit a fire around the country, so that everyone wanted high dose rate brachytherapy. We're talking almost 30 years plus ago. And so I said, well, you know, it's still better than radical prostatectomy in my, you know, mind. And so I said, so I'll do it, because that's what the patients are clamoring for. That's what they want now. And I set out to do it. And I learned, because I was one of the first people to do it in a big way, that with high dose rate brachytherapy, you had to fraction it, meaning we had to give 5 to 6 sessions to get an equivalent result as with permanent seed implants, where you just put it in once. And to accomplish that is very difficult, because what I would do at the time is, knowing that a patient, if he's going to be told he has to come back 6 times and I'm going to put needles in his butt 6 times, he's not going to show up for the second one or the third one. And so, unfortunately, that was also learned by others. And more recently, when HDR became popularized again, they're only doing 1 or 2 sessions for that reason, because they know the patients won't go for it. In contrast, back in time when I was doing it and I was publishing on all this, again, I realized it would take 5 to 6 sessions. There was no question about that. But I knew patients would run, so what I would do is put the needles in, admit the patient to the hospital, leave the needles in, and the patient would have his legs in a semi-lithotomy position. I'd have to put a catheter in the urine because we'd have to drain it. We would have to we'd have to control his bowels because he's lying there in a bed. And what I would do is treat them 2 to 3 times a day, every 8 hours. And I did that, and it was, and that gave the result that I wanted. But I really hated to do it. And patients by the end of that 5 or 6 times just saying, get these damn needles out of my butt, because it was hard. And it also had more infection rates. And I didn't like it. And as soon as I could get away from it, I did. And the reason being is that we like to think in terms of precision radiation these days. We want to be really precise about our delivery systems. And so, those of you who are treated here, we have a really sophisticated type of external beam radiation that we call DART. But seeding is maybe the most precise radiation of all. Well, with permanent seeds, the way it works is that the dose is delivered exactly where you put it. And if you go about 1 millimeter out from the prostate, the dose falls off significantly, 10 to 20 times. And we call that the radial dose fall off. So in essence, if this is the prostate, and if there's a tumor here and I put seeds in that tumor, that area is going to get treated, and only that area. And so I have to be very precise about what I do to target that tumor. Okay, that's how it works. If I were to put these seeds in today, or depending on the isotope, they would have expended their dosage within 2 weeks to, say, 3-4 months. And they would have done their job, and I wouldn't have to do anything else. In contrast, and when you look at radial dose fall off, if you look here, 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 well, this area, that dot right there is getting fraction of the dose at this area right here, because what happens is regular tissue, attenuates the dose so much that it really doesn't allow the escape of the radiation dosage. And that's important. Okay, so that's what it's all about with brachytherapy and permanent brachytherapy. In contrast, when you do a temporary implant, you put the needles in, and through these needles, as I was saying, you thread a radioactive isotope to a select point, and it goes down. The problem is this. With temporary needles, you use an isotope called iridium-192, and it's not so precise. In fact, if you look at doses here or here or here, they're getting the same doses here, or right in the middle of the tumor. That's the problem. In fact, when I was doing this extensively, high dose rate, I would not only do it 5 or 6 times, but with every treatment, I would have a person wear a lead shielded goggles so they would not get cataracts. And those are kind of some of the reasons I favor, in a very big way, the permanent isotopes, just because they're far more precise. It's a one and done. It's been very well established, their safety in the literature. So I don't think also that 1 or 2 sessions of high dose rate fractionation, those 1-2 sessions instead of 6, is enough, sufficient. But I think the reason why they do that is for the reasons I've told you. They just know that patients aren't going to do it 5 or 6 times. Any other questions? Yes, sir?
Yeah, we've got a lot of questions. One is, when you get prostate cancer, your surrounding lymph nodes also get cancer. Can you see those lymph nodes on the CT scan or the ultrasound or not? And how are the lymph nodes treated? Are the beams directed to the lymph node also?
Yes. So the gentleman's asking about lymph node drainage. So the prostate region is chock full of lymph nodes. There's hundreds of lymph nodes that live really close to the prostate. And I mean, they're like this, these tiny little dots. Lymph nodes are organs in our bodies that are there to remove things that are not supposed to be there. Classically, they remove infection or inflammation. And, you know, many of you may know that, you know, if you ever had a swollen lymph node under the, right around here, and it accompanies a sore throat because the lymph nodes are trying to remove foreign inflammation and infection. Similarly, though, lymph nodes recognize foreign things and it grabs cancer as well. And prostate lymph nodes are very commonly affected, affects lymph nodes, and there's a select drainage that we know prostate cancer goes to. We were involved right here with a nanoparticle test, which is better than any test I've ever done. Unfortunately, it's not available anymore, and we did it between 2008 and early 2019, and it was almost a perfect test for lymph node drainage. And what I found with that test is that even the low-grade tumors, the low-risk tumors, commonly had involvement of lymph nodes, and it was just a common thing. To the point that I realized that if we're gonna, you know, make a big change the landscape of prostate cancer treatment and up the cure rates, we better treat those lymph nodes. So that was something that I learned a long time ago, and we know these lymph nodes are involved, so we do treat them. And the type of treatment that we give here combines the DART, which is dynamic adaptive radiation therapy. And typically, if we know a patient has lymph node spread, we often do use hormones simultaneously to get the biggest impact out of it. But lymph nodes are right with prostate cancer. They're really, I think they're underappreciated because many studies don't show it. Now, because I lived and breathed nanoparticle tests and seeing exactly where lymph nodes are, I think here at our center, we do have a really good feeling and handle on lymph node decimation. And we do fine section light speed helical scans as part of our imaging, which we develop a treatment plan. And we can see those lymph nodes very, very well. They're very well delineated. If they're enlarged, then it's really clear. But even if they're not involved or enlarged, I typically would treat the real nearby lymph nodes of the prostate. And there was hundreds of them. Interestingly, a long time ago, with radical prostatectomy, an incision was done from the belly button all the way down. And they used to open it up and then pluck lymph nodes out. And they would often remove 15 to 25 lymph nodes on each side, and would argue that that was a good way to figure out if your cancer did go to lymph nodes. It was a good way to take those cancer from the lymph nodes. The problem that they found when doing that is that, so lymph travels from your toes to behind your ear, and that's the direction it's always going. It's always going up, okay? And so what happens is you need the lymph channels to be intact for the lymph fluid to continue up and out of your body. Think about it, if you remove these lymph nodes, you're blocking the pathway of lymph. So what ends up happening is downstream, the scrotal sac, the penis would become engorged with lymph, and it would become, we call something lymphedema, and your lower extremities would swell. And that's the reason why they got away from doing that with radical prostatectomy. Now, interestingly, with the newest, latest, it's been 30 years now, but Da Vinci robotic laparoscopic prostatectomy is not done with large incisions. And they do remove a couple of lymph nodes, and that's as much as I often see because they don't have a very good visualization of them. And the ones they typically remove are down here and very close to the prostate. The problem is those are rarely involved. So it is a shortcoming, I think, of the Da Vinci robotic procedure, because while you don't really have to remove a lot of them to get the lymphedema and swelling, but you could at least sample a couple of them, but they can't get there. It's just not possible. So anyhow, lymph nodes are really commonly infected with prostate cancer. We do treat them with the DART radiation effectively. We zero right in on those lymph nodes, and it's part of the treatments. It's away from the prostate itself. So we're treating the prostate, but we're also treating lymph nodes. And sometimes we have you come back later on for some lymph node treatment as well to make sure we've gotten to a definitive curative dose. Yes, sir.
Is a biopsy often always required if you have a MRI and you have a PI-RAD4 lesion, you have 3 PI-RAD4 lesions? Is there always a biopsy required after that?
Yeah, so he's asking the need for a biopsy, if you have some, clear-cut evidence on a scan, like an MRI, that you got a cancer, and the unfortunate answer is yes. Okay, we hope to come to a time where that's not necessary, and more there's tests we call liquid biopsies, where you take it from the blood, but unfortunately with prostate cancer, if the insurance companies are gonna accept any kind of treatment, if they're gonna even do diagnostic tests like PSMA PET scans, which is the one that's most commonly being done now. They want to actually see from the oncologist, we send them your pathology, and it has to come from a biopsy. So, there's some very clear-cut cases where it's like really obvious, but we still have to do the biopsy in order to move on.
Right, and then from there, a follow-up question, if I may, and then from there, the best method of treatment you would make that determination based upon what they found. If they were cancerous lesions or if they were benign lesions, of course, that
Right.
would be a much better scenario.
Yeah, so, based on what we find, we treat. So, on an MRI, it might be a lesion on the, over here, maybe a lesion over here, depending on where it is. Now, we also have our own tool, many of you know, it's called a three-dimensional color flow power Doppler ultrasound. And I do believe that it's even more accurate than an MRI. But we actually, when we do biopsies, we like to actually have both. So we actually fuse the MRI and we use the interactive real-time 3D Doppler ultrasound to target lesions.
That would be at the same time that you're doing the biopsy, I assume. They do them simultaneously.
Simultaneous, yeah. We do a lot of Doppler analysis here. Typically, prior to a biopsy, we would do a 3D Doppler ultrasound. And then with the same exact machine, and we have the same machine. We have three 3D color Doppler ultrasounds, and we make sure it's the same machine. We have the data from initially, and then when we do the biopsy, we're looking at it the same way. There's no guessing, but we like to have combination. And I published data on that board over there. It shows about a 97% predictive accuracy, meaning if the Doppler ultrasound showed me there's cancer, 97% of the time it was. So anyhow, yeah, it's very interesting. MRIs have gotten interesting. It was maybe a decade ago, and a radiologist reviewing an MRI, he could say, well, I think there's a cancer there in the prostate. But that's about as much as they could do. About 7-8 years ago, they started using bigger magnets. And so we call 3T magnets, 3 Tesla magnets, powerful magnets. They also started looking at it from the standpoint of not just imaging in one plane, but simultaneously imaging in many different planes. We call that multi-conformal MRI imaging, and sometimes called multi-parametric imaging, and they've gotten great. So whereas they used to say, well, you might have a cancer, now they say there is a cancer, and this is how we expect it to behave. And there's a scoring system that they use. It goes from 1 to 5. It's a PIRAD score. 1 is the least aggressive, 5 is the most aggressive. So they not only say there's a tumor here, this is the size of the tumor, but we predict it's going to be a PIRAD 3, a 5, 4, in terms of what they see. And that's valuable information also, because sometimes they've gotten so good that even with a biopsy, if the biopsy comes back and we see it to be less aggressive than a PIRAD 4 or a 5, we may still say, maybe the biopsy missed, because there's heterogeneity. I mean, there's differences in a tumor too, and a tumor may carry with it some lesser aggressive along with higher grade tumors. So we do pay a lot of attention to those PIRADS readings now with MRIs. Yes, sir.
How about a decipher test as the indicator? Is that used by you? And what are you for subjects?
I use a lot. We use a lot of these types of tests called Decipher, Polaris, and they're predictive algorithms. And what they basically say is, based on the pathology obtained, and sometimes it also is a liquid biopsy from the blood, the probability of the cancer being aggressive is X, Y, or Z. It would say it's very aggressive or not so aggressive. And I'll be honest with you, I've done thousands of prostate biopsies, and I've used all those different testings, and came to find it wasn't as clear cut to me, because many people who had, a low Decipher score, I'd find metastases to bone. And I kind of go more by the actual tumor now. I think the tumor tells me more information than the predictive algorithm testings like Decipher, Polaris, and there are others. OncoDX is also important, or done frequently, I should say. Yes, sir.
You know, as radiation continues, is there blood still flowing to the prostate?
Yeah, radiation doesn't impair blood flow. So a couple of things we talked about lymph nodes. So we can irradiate the lymph nodes, by the way, and not get into swelling, of the lower extremities or the scrotal sac. Similarly, with radiation, it typically does not impair blood flow. And again, we measure blood flow with our Doppler ultrasounds, and it's pretty clear. Now, what happens though is that there's also cancer blood flow pattern. So cancers themselves, they call for vessels. And what we commonly look at, for example, this is a tumor here. We like to see what is its vascular supply. And we commonly see it's reaching out here and calling in vessels to feed it. Cancers are sneaky, and they look for vessels to feed it, and we pick up on that as well. If there's no vessels to feed it, cancers take it one step beyond that. They create their own vessels. So, they're a perfect system. And their thinking is, if I can't get it from here, I'm going to create it myself. These are things that we pick up with 3D color Doppler ultrasounds. MRIs are also getting better at picking up vascular flow, but we like the Doppler. It's more specific to vascular flow. What we like about 3D Doppler ultrasound is a couple things. Number one, there are differences in gradients. So cancers being more dense, what you would find is this area is dense and it looks blacker on an ultrasound compared to the outskirts. And the outskirts may look shades of gray, and so we see a deep dark abnormality sitting in the shades of gray. We know what the deep dark abnormality is. So that's one definition of prostate cancer on a Doppler ultrasound. But the second thing we look for is blood flow. So those are the two major important tenets of prostate cancer with Doppler. It's going to show a harder area here. It's a hard mass, so it's deeper dark. The reason why it's deeper dark is because the ultrasound can't penetrate it so well compared to the other areas which it penetrates easily. But if it's got blood flow, we see that as well, and that's very important. And it's very important for follow-ups because many of you in follow-up come back and we do a Doppler ultrasound, and you've been treated now, 6 months ago or 3 months ago, whatever, and then you find out that all the cancer blood flow is not happening anymore. So it definitely does shut down that element of blood flow in the prostate. But if there's normal prostate blood flow, that typically is unimpaired.
Yeah, when you have beam therapy, the monitors on the side come out. What are those? How do those monitors work? What are they looking at?
So there's a lot of imaging that goes on when a patient's being treated with radiation. That's something that we are very involved with here. So we use everything from 4D ultrasounds to something called cone beam tomography, which here is a light speed helical scan tracking you while you're being treated. We use respiratory gating to watch breathing patterns and how things are moving, because respiration has a lot to do with not only your chest moving, but if you just put your finger between your belly button and your groin, you'll see you breathe with pelvic breathing, and things do move. And that's very important. There are other things that we use like Align RT and Vision RT, which also tracks your body in real time. And so the monitors, in addition to the actual linear accelerators, are tracking your real-time motion. And that's being conveyed to all the main terminals in the facility, and then we treat accordingly. Plans are changed on the fly.
How much progress must you make to sign your name on the wall?
Yeah. So that's what we call the Wall of Fame. And, if you take a look at it, you'll see we've pretty much I know we've dotted every single state in the union, and we have lots of countries, we've treated throughout the years, but It's a 5-year wall. So when you make it to the 5th year, you sign the Wall of Fame. Okay. And yes,
Are
sir.
lymph nodes involved where the cancer may have spread to the bones, around the bone area where it spread?
Yeah, so he's asking about lymph nodes and bone dispersion. So typically, commonly, if bone is involved with prostate cancer, lymph nodes are probably always involved. The reverse, though, lymph node involvement does not necessarily mean it's going to go to the bones. Okay, now there's also cases where you can have isolated bone lesions and no lymph node involvement. So, cancer takes a different pattern in everybody. But generally speaking, the way prostate cancer works is it grows here, it then goes off to the lymph nodes, and as I said, the lymph nodes are moving north. And so they keep going up, up, and up until it finally gets to some bigger vessels and it releases the lymph in the fluid, and that's when it contains the cancer. And that those cells then migrate to other areas of the body, be it the bone, the liver, the lung, things like that. So anyhow, lymph nodes are something we would call harbinger of metastatic disease spread, because if it's been in the lymph nodes long enough, as I say, they're not sitting still. They're moving. That's just the nature of lymph node dispersion. We have ways of treating, though, men who have lymph node disease, men who have both lymph node and bone disease, or men who just have bone disease. So they're pretty good agents. For example, and again, many of you may know about a drug that we call Xgeva. And Xgeva is a monthly or quarterly injection, and it's specifically for bones. And prostate cancer uses a specific enzyme in bone. It's called the RANK-L enzyme, and it uses that particular enzyme to propagate. So it really needs it. It wants to have RANK-L enzyme around, and it feeds on that, and fuels it, and it makes one area of the bone go to another area of the bone and another area of the bone. So Xgeva, also called denosumab, actually shuts down that enzyme. So we like to use Xgeva as an anti-bone cancer agent. Similarly, we use isotopes, which we call radioligands. And what they are is they're injectable isotopes, which travel through your body and go right to the bones, including areas that we don't even know about, where there might be bone early on, we just doesn't show on a scan, but it's called Sofigo. And we typically do that every 4 to 6 weeks for a frequency of 6 times. And it works very effectively. So those are a couple of things that we like to use for bone. There's another agent that we use, which is a hormone. And while hormones do have their effects on bones, we specifically like one called estradiol patches because it happens to have a really good effect on bones. And in fact, it's been used for strengthening bones, but it also is used here for its anti-cancer properties. Okay. Yes, sir.
Question back about the seed implanted. That's permanent, you said. Do they ever dissolve or they stay in the prostate?
No, they stay. They're made specifically the body doesn't reject them. So they're tissue compatible from the get-go. They don't interfere with MRIs or pacemakers or anything like that. So they're designed to specifically stay there and go nowhere. And that's what they do. There's some types of isotopes that I prefer, which do hang around. In other words, a long time ago, I had recognized that when putting these tiny little seeds in, but if you blew up the seed a lot, you would find that there's 2 types of seed. One is shaped like that, blew it up 100,000 times, and the other one is shaped like this. I don't like this one because if you put it in, I published a long time ago about putting seeds and even putting them just beyond the reach of the prostate edge. And I got a lot of calls from doctors saying, well, we're following what you wrote in the papers, but our seeds are moving. And I came to realize they were moving, or they came to realize because they were using a seed that had convex ends. And this is the type of seed that moves around. Whereas this one here it has these concave ends, and I have a specific instrument, Dr. Sony and I, that we put right like this, and we swirl it, and it locks in. Tissue kind of locks it in forevermore. And there's no need to remove them. You know, they just stay. They're tissue compatible. They don't interfere with anything. That's pretty much it. They don't cause, you know, any trouble down the line. Any other questions? Yes, in the back.
Some patients might say, I'm scared about losing control of my bladder or my ability to function sexually. How do your treatments protect those?
So she's asking questions about issues with bladder control and issues with sexual function. So first, let me digress to talk about radical prostatectomy, okay, which I've done. And prostate is surrounded by many critical structures. So, for example, the bladder comes down like this, and there's a really big valve here that we call the internal sphincter of the bladder. And it has all to say with urinary patterns. So right now, you know, if you want to control your urine, if you want to stop, if you want to go, if you want to hold it, if you feel you got to go, it's all about this big muscle here called the internal sphincter of the bladder, but it reaches down and coordinates with the prostate at the level of the area we call the prostate urethra, which is the pipe that carries it out. This is the anatomical arrangement of that. This continues down, and there's another group of sphincters down here. These are called the external sphincters. They're really small. And I've probably spoken to many of you on the phone or something, and I've told you that these sphincters have little to say with control of your urine throughout your life. Maybe you're using up to 5% of the caseload for your urinary control. Meanwhile, prostate also has the rectum behind it. I can't show you that on the picture, but it's right behind it and often tethered to the prostate. And then you have nerves, arteries, and veins off to the right and left side of the prostate. The prostate's a sexual organ, and it's the G-spot in men. It has everything to do with creating the seminal fluid. Prostate makes most of the seminal fluid, which then gets stored in these appendages or reservoirs above the prostate. We call them seminal vesicles. And the other aspect of the prostate is a very nervous area. So it's got a lot of nerves going from the inside to the outside to reach what we call nerve bundles outside the prostate. Prostate also has a lot to do with the orgasm in men. And upon orgasm, the prostate mechanically contracts and pulls the fluid from these seminal vesicles. There's ducts that will come down and meet the prostate and send it out through the penis. So with respect to surgery of the prostate, it's bound by so many critical structures that the best you could ever do is peel it off the surrounding structures. In most cancers, if this was a tumor anywhere in the body, you would always remove more than that tumor because you knew that the tumor is infiltrating around it. And so you take something like that. Can't do that with the prostate because it's bound by too many critical structures. So when you do peel the prostate with radical prostatectomy off of the surrounding areas, that's what you do. Peel it off. You come around like this, and you come around like this. You try to take out the seminal vesicles if you can, but you have to take out that big sphincter. And then you come down like this. Because this sphincter was paramount to controlling your urine, it's gone. So most men who've had their prostates removed immediately thereafter, they can't control the urine. It's trippage, you know, leakage. And they now have to rely on the external sphincters to make up for a really big sphincter. And it's rare that they can do the full job. Many men spend, you know, up to 2 years after having the prostate removed, trying to build up the remaining sphincters with pelvic floor exercises, and there's different things that can be done. And they may get to the point where it's not so bad, it's not a quality of life killer, but when they sneeze, when they laugh, when they cough, when you run, you do things rigorously, it'll probably squirt out some. And even if you're the guy who doesn't have a leaky faucet, you know, you'll probably wear a pad to control your urine, to protect your clothes. The other thing that happens is the nerves invariably get severed. And that's a big deal because again, there's nerves going out like this from the prostate, and they're carrying an impulse down that goes to the penis. So if you imagine if the prostate's removed, you lost all the nerves inside the prostate, but you also going to have one of these or two of these nerve bundles nicked. And so classically, men who've had their prostates removed, the two complications, urinary incontinence, complete sexual dysfunction. And, many men, I probably told you, opt for, penile implants because they can't get an erection anymore. And they may do that only to find they can't get an orgasm anymore, because the prostate has a lot to do with that process as well. The two areas of the male genitalia that have to do with sexual dysfunction, sexual erections, would be the prostate and then the penile glans penis of the penile shaft. And you just never know how much is which one. But again, most commonly you're losing 50% of the function just by removing the prostate, let alone nicking a nerve. So those are the major side effects from radical prostatectomy. So when we do treatment here, what we try to do is something we call nerve sparing. So we recognize where nerves live and we try to lessen our doses to those nerves. We also try to avoid irradiating the bladder neck because that's the sphincter. And if we do treat that area, it's going to be problematic. Now, we also know that sometimes prostate cancer likes to grow north, and this could be a cancer, and it could grow into these areas. And in those situations, we have no choice but to treat these areas, including the sphincters, and those men may have more urinary bother, but it's typically temporary. So, when we're doing it immediately afterwards, you may have some more inflammation because things may not be working so rhythmically anymore. But it typically comes back with time, and that's why a tincture of time is really what it takes for patients to get back their bladder control fully. And most men do, and I think, when I look at most men after the procedures, a year or two, and I look at when they came in, this is what they filled out on their urinary profile form, and now they're filling this out, and it's often the same and often better. And it's often better because prostate really does shrink a lot, with radiation. And we often see prostate shrinkage as much as 50%, sometimes 80%. And if that prostate volume was also pushing up on the sphincter, then it releases over time because radiation is shrinking it down. So we really do go out of our way to avoid the unwanted complications of incontinence, which is really nothing we just don't have that in our vocabulary here. Leakage issues, sexual function. That's something that's possible, and sometimes we just don't know why. We didn't remove the prostate, but the prostate's a sexual organ, and anything you do to it could affect sexual function. Most commonly, though, prostate again makes most of the seminal fluid, which is the ejaculate. And because you're treating the prostate, some of that function is shut down. Most men, when they come back for follow-ups, say 5th year or 10th year, and they write on their profile that their seminal fluid, the ejaculate, is diminished in volume and changed in consistency. And that's typically what it is. I've had many men father children, whether they wanted to or not, and then they tell me, I thought I was infertile. I know I never told you that. Because what typically does come out is the sperm, which is interesting. So, yes, sir.
Yeah, I finished my initial external beam treatment 2 days ago. At midpoint, I had a CT scan and ultrasound, but at the end of the treatment, there isn't any progress assessment.
There isn't, I'm sorry?
Progress. The midpoint, they looked at progress, but at the end, there's nothing. No CT scan, no ultrasound.
Well, the CT scan could be done. Okay, whether insurance pays for it is another issue. So CT can be done. We don't do ultrasounds immediately after treatment, and the reason we don't is because there's typically too much inflammation, and we can't You just can't see anything but inflammation. And whereas in the midpoint, it's not so, it's clear. Everything is still clear and we can see more and make more sense of it. But afterwards, we don't. So the reason why we do midpoints, and sometimes we do it 3 times, is to better define our treatment. But once the treatment has been defined and over, then we don't have to do it immediately. And we don't really want to do it immediately because we can't tell heads or tails about the prostate until about 3 months after the treatment. So we typically do it.
Just another question.
Yes.
What are the 4 dimensions involved? We live in a 4-dimensional world, but that's not what we're talking about. What are the 4 dimensions in your system?
Well, the 4 dimensions are everything we know in terms of anatomical boundaries. But then, you got the 5th dimension, which is motion. And that's what's all important here, is tracking your body's motion in real time.
Can
Yes,
I
sir.
give you one hypothetical? I'm great at that.
All right.
So if a lesion is determined to be cancerous, that you would do everything possible not to remove the prostate. So you could do specific, like isotope treatment to try to maintain the prostate. If it's maintained within the prostate, it hasn't spread anywhere.
Yeah, so I think you're just asking about if you had a select tumor, an identifiable tumor. Maybe you want to rephrase that.
How can I rephrase that? Okay, let's see. So if you have an identified lesion
Yeah.
following the MRI scan, the one they do down in Calhoun Road,
Sure.
and they find something there, so you need a biopsy. You already told me that.
Yes.
So you do the biopsy, you find out it's cancerous, but it's confined to the prostate, and it's a small centimeter. They're not large; they're small. Can they do a specific treatment to keep the prostate
Okay.
rather than do a radical prostatectomy?
Right. So he's asking if you had a definable tumor and without evidence of spread, can you just have a treatment directed to that definable tumor? Yes? That's your question?
Yes.
Okay. So when I walked away from radical prostatectomy, and the reason I did is because, sure, men had the complications of incontinence and sexual dysfunction. But what got my attention, because at that time, this is a big hospital in New York, the urologists there, top neurosurgeons in the world, they were telling me this is the most curative thing to do. But I was also following men in the clinic, and I was seeing 30 to 40 guys every day who had their prostates removed 2 weeks ago, 2 months ago, 2 years ago, only to find their PSAs were rising again. And patients were shocked because they didn't think that could happen when it's actually a very, very important and popular frequent event with prostate surgery. It's just that you're not told up front. Now, because of that, I just got away from it. I did my own studies. I talked about this around the country. And you may even see it on the website. There's this talk I give. It's called Show Me the Data. And I'm looking at the best universities in America, Johns Hopkins, Sloan Kettering, Cleveland Clinic, and I'm showing just how high the failure rates are after radical prostatectomy that men are not aware of because they're told by their urologist it's not the case. So after that, I said, well, maybe I can do something else, at least lessen the complications. So this gentleman is talking about what if there's a definable lesion right here? And so another type of therapy is called ablative therapies. And there's 2 types, focal laser ablations. One uses a freezing, the other one uses a heating. The freezing is called cryosurgery. The heating is called HIFU, also known as TULSA. And what you basically do is you put a probe right into the tumor, and then you just heat or freeze that tumor. Okay? That's the basis of that treatment. Now, you can't go out very far because, again, there's critical stuff out here. And if you freeze or ablate it, you're going to completely destroy the nerves and tissues outside. So you have to keep it within the prostate confines. Okay, whereas with radiation, we could go a few millimeters out and not bother anything because tumors wither away and the normal tissues just repair. However, what I came to find by doing this, and again, focal ablative therapies, is a couple things would happen. Number one, why was I doing it? Well, I was doing it to lessen the complications because all I had to do was treat this one area, and that's the way I thought it could be done. But let's just say a PSA is 6. So you do this procedure. After the procedure, it's 2 or 3. Great, it's 2 or 3. But by a year, it's 4 or 5 or 6 or 7. Why is that? Well, it's because another area of the gland became malignant. Prostate cancer grows by a concept we call field cancerization. And what it means is that every single cell of the prostate, and there's trillions, have been subject to the same environmental cues, genetic, predisposition. Every single one is getting the same information so that over time, the prostate cancer all morphs to become malignant. There's 2 sites in the body. It's very interesting. Women having breast cancer is very similar to the prostate. And those are the 2 classic areas we know of that grow and propagate by this method we call field cancerization. And it's also interesting because breast cancer is fed by the female hormone estrogen. Prostate cancer is fed by the male hormone testosterone. There's this propensity for lymph node dissemination in breast cancer. And you often hear women who have lymph nodes under the axilla. The other in prostate cancer is the same. But the third thing is that they both grow by field cancerization, meaning you better treat it all, because if you don't, then other areas of the prostate could be involved. And when I came to recognize that virtually every single patient who had a focal ablative therapy is going to come in for 2 or 3 or 4 or 5 times. And I just recently treated a man from California, and he had 7 times. And by the time you're into the second one, the whole objective why you were doing this was to lessen side effects. And you've already gained all the side effects you didn't want to have. And then you're still not over with the cancer process because it's going to grow elsewhere. Now, another issue that's really, really important, because when I first did focal laser ablations, when I first did seed implants, it only treated areas that were cancerous in the prostate gland with seed implants, permanent seed implants or temporary seed implants. I still scratched my head with respect to failure patterns. I wasn't seeing them as readily as I did with surgery. And in contrast to surgery, where when cancer does come back after surgery, it often comes back elsewhere: lymph nodes, lungs, bones, liver. And the reason we think that is because there is dissemination of blood at the time of the operative procedure, which is also a contrast to many other cancer surgeries where you don't lose blood. Prostate surgery, you lose a lot of blood with radical prostatectomy. That's a big deal. So that when I was doing focal therapies and I was just treating that area, or I was doing seed implants only, I still didn't understand what's going on with the failure pattern. I spent time in the surgical pathology lab to find a very interesting element about prostate gland, and that is that it does not have a capsule. Most organs in our bodies have capsules. Certainly everything in our urogenital system has capsules. The bladder has a really thick one. The kidneys have even thicker. The prostate has none. And the reason why that's so important is because prostate cancers, by and large, begin in the area we call the peripheral zone. You can just think of it as the edge. It's the periphery. Okay, they rarely begin in the center. But when they begin on the edge, which is 99% plus, what happens is the cancer leaks out. And this area of leakage is not being addressed by the focal ablative therapy, nor with the seed implants. Okay, and that's actually when I recognized or realized that I would need something else to clean up the act. And these same fronds or tentacles end up going to the lymph nodes around it also. So these are the reasons why I came to the recognition that unless we treat not only the lesions themselves, but some adjoining areas, which with radiation you can do pretty cleverly with precision radiation, and you can get right outside the prostate and you can get to the lymph nodes, that I was not going to, really make a big dent in the disease. But once I did start combining the radiation with seed implants, it was a game changer in terms of cure. And in contrast to these therapies, and of course radical prostatectomy has its own complications, the ablative therapies also do, because when you do ablation, it leaves behind a big scar, and that's going to be there forevermore. And it's just a big scar in the prostate. And, the more you have 1 or 2. And, what will happen is the doctor doing it will say, all right, well, we have another cancer here. We'll just do that one too. And, you start gaining a lot of a lot of fibrous tissue in your prostate, scar in your tissue, in your prostate. And that it lends itself into other problems urinary wise. So I think, does that answer your question?
Unfortunately, yes.
Anyhow. So anyhow, that's why I abandoned seeds alone a long time ago, and I started going the direction of combined therapy. Or, many of you know that we also do just DART alone. And we're pushing the boundaries of that too, because we've learned that we can give higher doses here. And we think like one of the big advantages of brachytherapy, is the dose. We get pretty high with DART. Unfortunately, we just don't have that body of literature available to us, to say, okay, I treated 10,000 men with DART because it's too new, compared to the radiation group, but it seems to be really, really good. Yes.
I realize that I'm very fortunate that I've got the best chance of recovery. In Pottsville, Pennsylvania, the urologist referred me to an oncologist who gave me Xtandi and walked out of the room. Would you be okay or recommend this excellent book to give to the urologist who had no idea what to do?
Oh, they won't read it, I assure you. They only read their own propaganda. They really do, and there's 100 of them to one of me, So, yeah, and that's unfortunate because they rule. They rule the world of prostate cancer, and they're going to tell a guy, and they always tell the same story. They've been telling for 25 years, and say, you should have your prostate removed surgically because if you have radiation, we can never do it again. We can never remove it surgically. Meanwhile, it's like you probably wouldn't want to have it removed surgically, or it could be removed surgically. It's just that may not what you might choose. Anyhow. Yes, sir.
You mentioned earlier about hormonal therapy being part of the treatments. Is that always going to happen, or is it optional, or what? How do you treat hormonal therapy?
Yeah, we're not big hormone bugs here, but we know when they're necessary. So I'm the last to push hormones on you unless I feel they're necessary. And in many cases, they're very, very necessary. I mean, they work. And we know that when you deliver hormones simultaneously with the radiation, you upregulate your immune system. And it has a profound impact on the cancer because you're strengthening your immune system. Both radiation and hormones, each of them independently boost your immune system. They make your immune system stronger. Now, chemotherapy drops your immune system. Surgery drops your immune system. These two don't. So when we need the extra help, we do combine hormones with radiation. There's no question about it. And now there are second-line agents, just as this gentleman says, Xtandi. There's a whole new world of second-line hormonal agents, which we put men on, and they have an even bigger impact than the primary hormonal therapies. And now we're finding that we could even, while we use both of them simultaneously, primary and second line, we're segue into just using the second line because they don't even drive your testosterone down. So men can still have testosterone, in their bodies and feel good about it. All right. Yes, I think we're going to take one more question here.
Could you ask Marty McCary to reinstate your nanotapes?
Oh, we would love to have nanoparticles back.
Ask Marty McCary to reinstate it. Explain it to him.
Yeah. No, we've tried. We've tried. It's a real unfortunate thing. It was the best test. It's still available in the Netherlands. We work with the Netherlands also. There's a paper back there. You could read it on nanoparticles and just how accurate it is. It's pretty remarkable, but it's just not available anymore. And the Netherlands has an over a year wait, I'm told now. So, anyhow. All right, well, that'll conclude our meeting. Thanks for coming. I really appreciate it. You're gonna make it again.